Hello, I'm Dr. Jenny Andrus, and welcome to our very first episode of Joint Ventures. In this OSC original podcast, we'll discuss the latest medical news, diving deep into the science, the controversies, and of course, the applications to musculoskeletal medicine. Medical news, when presented in the lay media, is oftentimes sensational and even frankly contradictory. We do all remember when eggs were bad for you, but OxyContin was safe, right? These things seem to change from day to day, and you'd get whiplash trying to follow the news trends. It's hard to know from a 60-second snippet on the news or a quick social media headline really what to make of it all. Our goal here is to critically evaluate the latest medical news in a non-biased way and present it in a format that makes it easy to understand. Patients will often ask me what I think about a medical headline, and in the office, we just don't have the time to really get into the details. This forum is a great way for us to go through these topics in more detail, and I'm really hopeful that it helps you make better decisions about your health. Thank you so much for tuning in and really for exploring this exciting opportunity with us. Now, before we get into today's topic, let me give you a little background on me so that you know where I'm coming from, and of course that I'm legit. I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. I'm a medical doctor who treats painful musculoskeletal conditions. Many of these conditions, especially spine ones, are treated with minimally invasive procedures, which I do also perform. I also do non-operative care for chronic orthopedic conditions. So basically, I'm the doctor you're going to see if your spine or your joints are bothering you, but you don't need or are not having surgery. I've been at OSC for 15 years, and getting older has, well, maybe one great advantage, and that's that I've seen a lot of ideas come and go. Some have really advanced musculoskeletal medicine, and some have fallen very flat. Being able to tell the difference early on is the tricky part, and that's what we're going to be teasing out right now. So let's get right into today's topic, Journavx. I may say Journavx or Journavx. I've heard it both ways. This medicine was recently approved by the FDA and has gotten huge amounts of buzz as an exciting non-opiate and non-addictive alternative for pain control. In the last 20 to 25 years, there has not been a new drug class approved for pain, so this is major news. The opiate epidemic has scared both patients and definitely doctors, so everyone wants to stay away from them if possible. That, in part, spurred the development of Journavx, and now it's available for short duration use in acute pain. More on that in a minute. Journavx specifically blocks voltage-gated sodium channels subtype 1.8. These receptors are in the nervous system and are necessary to transmit pain signals. This subtype 1.8 is present in the peripheral nervous system, so that means outside of the brain and spinal cord. This receptor is also present in a specific area called the dorsal root ganglion, and that's an important area where pain signals come into the spinal cord from the rest of the body. By being able to block these outside of the peripheral or outside of the central nervous system, it should not have the potential for addiction. That's exciting and definitely differs from opiates' mechanism of action. Opiates work on a few different receptors, most importantly the mu or the kappa receptors, but this is a central mechanism of action and is associated with a risk for addiction. Now, an important thing to know is that Journavx is approved for acute pain. Think post-surgical or post-injury. The vast majority of patients studied in the Journavx studies were post-surgical patients. We'll get into that a bit more in a minute, but just keep in mind that we aren't talking about long-term use or chronic pain. Currently, for acute pain, NSAIDs or opiates are most often prescribed. Sometimes, when there's a significant neuropathic component to the pain, like for instance shingles, antiepileptics like gabapentin may be used acutely, but for most instances, the NSAIDs, the nonsteroidal anti-inflammatory drugs like your ibuprofen or naproxen, or opiates like hydrocodone or oxycodone are prescribed. NSAIDs are highly effective, but certainly they do come with some concerns like bleeding, gastrointestinal issues like ulcers, the effects on kidney function and blood pressure, In spine fusion surgeries, they can reduce rates of complete bone fusion, so they aren't used right after surgery. Opiates are also effective for the majority of people. However, they have some risk. Now, people are immediately going to go to concerns about addiction. However, the other effects of opiates are much more common. Effects like respiratory depression, where a person's breathing is decreased, obviously bad. Confusion, sedation, nausea, constipation, itching, and urinary retention, where you can't get your urine out, are all things we see much more commonly than addiction. Journavx definitely works differently, and being able to block the pain signal before it gets into the brain and spinal cord could be a game changer. All right, so the point is it? Well, let's look at the studies a bit. They are randomized, placebo-controlled, which is the gold standard for study quality. So right off the bat, that's great. Study 1 was in postoperative abdominoplasty, which is a model for soft tissue pain. The doctor's cutting muscle and soft tissue. Study 2 was postoperative bunionectomy, which is foot surgery that involves cutting bone. So that's a great model for bone pain. In both cases, the measure of interest was pain intensity over time. Both studies looked at 48 hours of pain control. I know, that got your attention, right? Gets mine. That should immediately get your attention. That's not very long. They compared Journavx to hydrocodone 5 milligrams, which is a low-dose opiate, also called Vicodin, as well as to a placebo, which is a fake pill with no active medication at all. All of these patients could take ibuprofen. Yeah, right there we have a problem. Ibuprofen is highly successful in reducing inflammation and pain after surgery. So allowing people to take this during the study period really confounds things for me. So keeping that in mind, you have a placebo, a low-dose opiate, and Journavx being tested head-to-head. The addition of ibuprofen, that kind of throws a wrench into things, but let's just focus on those 3 options. So how did Journavx compare? Well, it was better than placebo, with placebo reducing pain 31% and 38%, and Journavx reducing pain by 47% and 51%. Okay, did you catch something important here? It reduced pain by about 50%. That is really important for people to understand. Medicines make it to market with less than 50% reduction in pain. My patients are usually dissatisfied with pain control this low, but it's important to see that getting 50% pain relief is considered significant in these studies. That has more to do with the limitations of what we actually medically can do and the complexities of measuring pain. And maybe we'll get into that in another discussion, but for now, recognize that 50% pain relief is considered significant. All right, so let's go back to the studies. Journavx works to reduce pain by about 50%. Great. So how does it compare to low-dose hydrocodone? Well, it's not superior, that's for sure. Hydrocodone reduced pain 43% and 53%. So there is not a statistical difference in pain reduction with hydrocodone versus Journavx. So it's not a superior product when strictly looking at pain reduction. Also, they compared a low-dose opiate to Journavx. Would a higher dose opiate have been superior in pain control? Maybe, probably. Journavx is a standard dose, which is only reduced in patients with liver disease or when it's given in combination with other medications, so just increasing the Journavx would not be an option. So what else might be important besides pain relief to make you decide to use Journavx? Well, side effects, right? We talked earlier about all of the risks with opiates. So how did Journavx compare? Well, only 0.6% of people stopped Journavx early due to side effects versus 0.2% of placebo. That number would typically be expected higher in opiates. Itching, muscle spasm, rash, nausea, vomiting, headache, constipation, and dizziness were reported the most as side effects with Journavx. But again, not many people were bothered enough by these to stop it, which is excellent. Now, they weren't taking it for very long, which is interesting, maybe concerning, but regardless, for short-term use, very few people had significant adverse effects. Now, nausea and vomiting are serious issues with a lot of medicines, but especially with opiates. Those rates were lower in Journavx versus hydrocodone, but they were very high in the placebo group too, so it's really unclear to me what that actually means. In the studies, the rate of nausea vomiting was 9% and 20% with Journavx versus 16% and 33% with hydrocodone. but it was 12% and 25% with placebo. So I don't think this data really helps me decide if there is a significantly less rate of nausea with Journavx. Also, these patients were just a couple of days out of surgery, and many people still have some nausea associated with anesthesia. So again, I really can't conclude that that's marked. But that being said, Journavx is likely at least somewhat better than hydrocodone with regards to nausea. Now, most lay press right now is really focusing on the non-addictive qualities of Journavx. And of course, when I first saw that, I was thrilled. Until I realized that as of now, this medicine has not been studied past 14 days, and the main studies were for 2 days. So, what is the risk of someone becoming addicted to an opiate after taking it for just a couple of days? We all hear a horror story about somebody's brother or uncle who had an opiate after surgery and was hooked on day one, and that is obviously very scary. But is that actually something that really happens or happens at a significant level? Well, I can tell you there's not great high-quality data on that issue. So I can't tell you if using Journavx instead of a low-dose opiate for a couple of days post-operatively is going to make any difference at all in addiction rates in this country. We can all get excited about this being non-addictive, which I am, but do people get addicted to the alternative treatment, i.e. an opiate, at any significant rate when given for just a couple of days? Again, we don't have great data on that, but the vast majority of doctors will tell you no. In a patient who does not have a history of addiction or some other process that makes them highly susceptible to addiction, just taking an opiate for a couple of days for acute pain does not typically result in addiction. Now, more studies are being done, and I am really interested to see what comes of them. There is a study on lumbar radiculopathy, sometimes called sciatica, in Journavx. Radiculopathy is pinched nerves in the spine, causing pain, and something I treat absolutely every day. So I would love to see a better medication option for that. Preliminarily, this study doesn't look all that promising, but we'll see. Another study going out 12 weeks and looking at diabetic neuropathy pain was also done, and I'm keeping my eye out for those results for sure. One report said that GFR, which is a marker of renal function, was reduced when Journavx was used longer. So we're really going to have to wait and see if it can be safely used longer term. All right, so what are the take-home points? What's important here? Journavx is definitely an exciting new medicine, and its novel mechanism of action is really a promising way to treat pain. As of now, it's only for very short-term use, and it isn't superior to a low-dose opiate in pain control. So what patients would this be best for? Definitely in a person with a history of addiction or alcoholism, someone who maybe has had difficulty getting off of opiates in the past, and a person who poorly tolerates opiates due to side effects or who is already on other sedating medications like benzodiazepines that opiates react poorly with. In a person who has significant breathing issues like COPD or cognitive issues like dementia coming out of surgery, then Journavx would be a better option than opiates. Also for people on opiates for chronic pain already, or for those who use them for opiate replacement therapy for addiction, this may be a good option to treat acute pain without ultimately having to increase their opiate dose. Now, it's pretty pricey at around $15 a pill, and it's dosed twice a day. Given the cost, the fact that it hasn't shown superiority to opiates, and the short duration it's currently used for, I don't see this replacing opiates right now for acute pain. I do see it as a really promising tool in certain patient populations, though. I am so excited to see the pharmacology of pain management getting some more tools. We have not seen any real advancements in the pharmacological management of pain in a very long time, and I'm really looking forward to see where this leads us. Thank you so very much for listening. I hope you found this helpful. Please come back for our next episode where we will explore the concept of obesity as a disease and what this means for your joints. Thank you again, wishing you good health, and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.